All right, welcome again. Good afternoon, everyone. This is the Congenital Syphilis Update webinar for California Emergency Department clinicians. I know there's a lot of interest in this topic, and I'm excited to get started. My name is Dr. Kelly Johnson. I'm an infectious diseases doctor, a clinical faculty member with the California Prevention Training Center, and a medical officer with the STD Control Branch at the California Department of Public Health. But more importantly for today, I'll be going over a little bit more about the California Prevention Training Center. I'll also be introducing our wonderful speakers, Drs. Lyon and Plotzker, and I'll be discussing our disclosures, our CME requirements, and some brief housekeeping on Zoom webinar tools for you all. Next slide, please. Great. So first, a little bit about the California Prevention Training Center, or CAPTC. The California PTC is a multidisciplinary training and capacity building assistance center. We're sponsored by the CDC, and we're a member of a network called the National Network of STD Clinical Prevention Training Centers, or NNPTC. Next. Here you can just see a regional map of the NNPTCs, and the California PTC, which is us, is shown in purple on the left-hand side of this slide. Our PTC covers California, Arizona, Nevada, New Mexico, and Hawaii. You can also see the other prevention training centers, which are in different colors on the map. So if you have colleagues in another state who have STD questions or training needs, you can refer them to the NNPTC, the national network, and to their local prevention training center in their area. And next slide. The other thing that the PTC does is runs the STD Clinical Consultation Network, or STD-CCN. This is a really awesome online clinical consultation network. You can go there, you can submit complex STI questions, and a subject matter expert will answer your question either by phone or email, whichever you prefer, and they'll respond to you within 1 to 5 business days. So really great resource. Just want to make sure you guys are aware of that. Next slide. Here are our financial disclosures. None of the speakers today have anything they'd like to disclose. And next slide. This is the CAPTC CME disclosure stating that today's webinar will be offered at 1.25 units. Next. Okay, important for you all, these are the CME requirements for this course that you must complete in order to earn that 1.25 CME credits. So you have to have registered for the webinar on the NNPTC site, and you'll need to stick with us for the full webinar today. This webinar has to be watched live and it has to be watched in full. Unfortunately, we cannot give CME credit to those who are viewing a recording of this webinar or those who only attend a portion of the webinar. Attendance will be noted as you all sign in. Finally, you'll also need to complete a post-course survey evaluation by a deadline of December 22nd. So following today's webinar, you'll receive an email notification. It'll come from that address you see on the slide, which is nnptc@training.org. This will be within 24 hours of today's presentation. It'll have a link for you to complete your evaluation. And that evaluation link will come to the email address that's the same one you used to register for this course. So you could think about adding that email address to your safe or trusted senders list. And sometimes, just to warn you, that email can also go to your spam or your junk folder. So if you haven't received it in 24 hours, think about checking those folders as well. Next. Great. In terms of processing, CAPTC's CME provider is the University of Nevada, Reno, or UNR School of Medicine. If you meet the CME requirements, you'll receive notification from captc@ucsf.edu in about 4 to 6 weeks from the evaluation deadline, and that will have a link to claim your CME credit. Again, same as the prior slide, to make sure you receive that email notification, please add captc@ucsf.edu to your safe and trusted senders list. Also, again, please remember, if you don't see that email in your inbox, please be sure to check your spam and junk folders as well. Next. Thank you. Regarding post-webinar materials, in 2 weeks processing time after this webinar has ended, you'll receive a post-webinar materials email notification, again from captc@ucsf.edu. This email will include a copy of the presentation slides, an access link to the webinar recording, and any other available course materials or handouts. Next. Okay, lastly, a couple quick housekeeping rules about Zoom. So device speakers, microphones, and videos will be turned off for the attendees except for the presenters. Chat will also be turned off, but Q&A will be turned on. So if you have questions that come up, please enter them into that Q&A box. Next. The way to use the Q&A feature is to click on the icon that you see on your screen at the bottom. This will open the Q&A chat window and you can type your question and hit send. If you want to send anonymously, then you select anonymous and we won't be able to see who sent the question. You can submit your questions up to the last 2 minutes of the Q&A session. During the webinar, I'll also be reviewing the Q&A, and I may answer questions directly in the Q&A chat or save them and answer them live by our presenters during the Q&A session towards the end of today's talk. If you have administrative questions, you can also submit those into our Q&A, and they'll be answered by our clinical administrative team, consisting of Elizabeth Olson and Lauren Blakely. Next. And now I have the great honor of introducing our speakers. So Dr. Kristopher Lyon is a board-certified doctor in both emergency medicine and EMS medicine. He's the Public Health Officer and EMS Medical Director in Kern County, California. He's a reserve deputy and medical team leader for a law enforcement SWAT team, which sounds amazing. And he works clinically as well on top of that, and he's the associate medical director in a busy community emergency department. Next. Great, and we are also privileged to have Dr. Rosalyn Plotzker. She's an assistant professor in the UCSF Department of Epi and Biostats. She completed a fellowship in sexually transmitted diseases with the CAPTC and the California Department of Public Health, where she now serves as a public health medical officer in the STD control branch. And next. Finally, if you have any questions, you can reach out to Elizabeth Olson, who's our clinical program manager. Her email address is as listed on this slide. Thank you so much for your attention, and I will turn it over to Dr. Plotzker to get started with the content of this talk.
Thank you so much, and thank you everybody for being here. I see we have a lot of participants, and so that's really exciting. I know that this topic is one that gets brought up a lot in our world of STD prevention, and so as you all know, we'll be talking about congenital syphilis, particularly in the context of emergency departments, and that's for California Emergency Department clinicians. I, as was already mentioned, have nothing to disclose, and our learning objectives today are going to be to describe California CS epidemiology and incorporate data into screening. Then I'll talk about the importance of prenatal syphilis diagnosis, evaluation, and management. And finally, I will be explaining and applying the CDPH recommendation specifically to confirm syphilis status of pregnant patients in emergency departments. So to get started with some epi, this is a graph that I have a feeling some of you have seen before. It is comparing the number of congenital syphilis cases to the rate of syphilis among females of all stages of syphilis, which I'll get into more detail about later in this talk. And it's looking at the increase from 2010 to 2019. So not surprisingly, what this really highlights is that as the rate of syphilis among females increases, which is this black line, we see a parallel increase in the number of congenital syphilis cases. Looking at this geographically, this is the rate of congenital syphilis by county. So you can see that we have higher rates in the Central Valley. There are some in the southern counties as well. And we're starting to see in 2019 more cases in the Northern California also. So historically, we saw more in the Central Valley, and now that's starting to extend, especially up to the northern counties as well. Now, this is looking at rates. This is looking at number of cases. And so I wanted to compare these two graphs just to start out, that we do see in terms of how many cases of congenital syphilis we're seeing. We see more cases of congenital syphilis in the Central Valley and in the southern counties, but I don't want that to be misleading, because we are seeing higher rates in the northern counties as well. Now, this is looking at CS incidence by race and ethnicity of the mother. And again, the same time frame going, I'm sorry, there's a little typo, it should say 2010, not 2009, but from 2010 up through 2019. And you can see that while there have been increases for infants born to white or Hispanic birthing parents, you see very dramatic rise in the rate among infants born to Black mothers or birthing parents. Now, in terms of screening, the CDC and the USPSTF syphilis screening recommendations are as follows. For non-pregnant women, it recommends risk-based screening. And for men who have sex with women, it also recommends risk-based screening. For MSM, or men who have sex with men, the recommendation is at least annually and every 3 to 6 months if at risk. For people who have HIV, the recommendation is at the first HIV evaluation and then at least annually. And anyone who's diagnosed with chlamydia or gonorrhea should be screened for syphilis as well. And in correctional settings, it's also recommended based on local or institutional incidents. So this is for non-pregnant patients in general. For pregnant patients, the syphilis recommendation screening is that you would screen all pregnant patients at the first prenatal visit, which is consistent with what's been recommended for several years. Ideally, that would happen at the first trimester. Some people don't initiate prenatal care until the second trimester. And when there's a question about whether a patient would actually be able to go to prenatal care or access just isn't optimal, it's fine to screen the patient with an RPR at the time of pregnancy confirmation. So if you have a patient who does a urine pregnancy test and it comes up positive, it's totally fine to draw their blood and do an RPR, and then you can treat if that's reactive, if you have, for example, a rapid test. You also are recommended to screen again in the third trimester. CDC emphasizes 28 weeks gestation. I included 28 to 32 weeks, more in line with what CDPH recommends. And then you can also screen the patient at delivery if the patient is considered to be high risk for infection or lives in a community with a high prevalence of syphilis. And then, of course, all patients who have a stillbirth, meaning a fetal death after 20 weeks gestation, would need to be screened for syphilis as well to rule out syphilis as a cause of the stillbirth. And this is a quote that we just say over and over and over again: no mother or neonate should leave the hospital without the maternal serologic status having been determined at least once during pregnancy and then again at delivery if at high risk. Okay. Now, in terms of who should be tested at third trimester and delivery, this is what this is what CDC identifies as things that are considered high risk. So having signs or symptoms of syphilis, of course, if they were diagnosed with any STD during pregnancy, having a history of syphilis infection, receiving late, limited, or no prenatal care, substance use such as methamphetamine use, IV drug use, other illicit drug use, if they're homeless or have unstable housing, which is particularly important. And then also history of incarceration, history of partners who have other partners or partners who are MSM, having sex in exchange for money, housing, or drugs, and then living in areas with high rates of syphilis, particularly among females, and living in areas with high rates of congenital syphilis. I highlighted these two because in California, we consider the state to be at high risk for syphilis, particularly among females, and for the state to have high rates of congenital syphilis. And so we'll talk about this a little more, but as a state, we recommend that all patients be screened in the third trimester for syphilis, and that's in line with these recommendations. All right, so that's just a little bit about epi and screening. I want to talk about transmission and pathophysiology, just so that we're all on the same page about the mechanism of this disease. So syphilis is caused by the bacteria T. pallidum. That's this little corkscrew bacteria on your right. And transmission is primarily via sexual contact. So that involves direct sexual contact of a lesion that's an infectious lesion, for example, a chancre. It typically happens early in syphilis, meaning that the infection happened within the past year. However, it can be transmitted during pregnancy via the placenta, so by vertical transmission, and that's how we end up with congenital syphilis. And this can happen at any stage of syphilis, so either early or late. And very, very, very rarely it has been documented that you can have transmission via blood, for example, a blood transfusion. This is very rare. It does not happen in the United States based on our blood transfusion screening programs. And it's not considered a bloodborne disease from an injection drug use point of view, but that's the additional way that this could be transmitted. The incubation period once exposure happens is 3 to 4 weeks. However, the range can be as short as 10 or as long as 90 days. Now, in terms of the natural history of syphilis, after exposure and that 3 to 4 week incubation period, about 30 to 50% of people develop what we call primary syphilis. This is when the patient develops a chancre, which is essentially a localized infection where the treponemes are replicating and it forms an ulcer. And so that is typically a single ulcer, although there can be more than one. It's painless, it's indurated, it has that clean base with rolled edges. I will show you pictures, I promise. And the thing about chancres is that they can go unrecognized because number one, they're painless, and number two, they can be in a canal, like an anal canal or the vaginal canal, and so they can go unnoticed. Sometimes you can have some regional lymphadenopathy along with that chancre. That will resolve on its own, and then in 2 to 6 weeks, the infection enters the bloodstream, it disseminates hematogenously, and then you develop secondary symptoms. And secondary symptoms are basically the response to disseminated disease. So signs include the classic rash. That's the vast majority of diagnoses are based on rashes. And you can see that on the palms and the soles about 60% of the time. Also on the torso. You could also see generalized lymphadenopathy. And you can have constitutional symptoms or flu symptoms. And then sometimes you'll see these like, take a good look at the mouth, you can see condylomata, and sometimes people will actually have symptoms of neurosyphilis, and I'll talk about that in a minute. That said, even if you don't treat this patient in 3 to 8 weeks, those secondary signs will also resolve on their own. And the small caveat to that is that about 25% of people will have a secondary event. So they might have condylomata that resolve, and then later they might end up developing patchy alopecia. So that can happen more than once. But the majority of people will have their symptoms resolve, and then they enter a latent stage where they're asymptomatic. So of the asymptomatic patients, about 30% of them can go on to develop tertiary syphilis if untreated, and that can happen anywhere from 2 years to 2 decades. Latent disease in general is divided into early latent and late or unknown duration. So early latent means that you have concrete evidence that the infection happened within the past 12 months. That can be based on a past serology. I'll talk about that in a couple slides. It can be based on exposure within the past 12 months. It can be based on recalling primary or secondary symptoms that happened recently. So there's multiple ways you can establish that. But if you can't establish that the infection occurred within the past 12 months, then you would consider that late latent or unknown duration. Neurosyphilis can actually happen at any stage. And as I said, transmission from mother to fetus can also happen at any stage. Okay, here are those pictures I promised you. Here are some chancres. This is a chancre on the left. You see a chancre on the penis. You also see multiple chancres. This is on the vulva. And then here you see multiple chancres on the penile shaft. You can also have chancres on the mouth. So here's a couple examples on the lips and on the tongue. So you want to do a good oral exam anytime you diagnose somebody with syphilis. Here's an example of a secondary syphilis rash on the torso. You can see that it can have these sort of flat maculopapular rashes that can be on the torso. Here's an example on the palms and on the soles of the feet. Sometimes they look a little bit crusted over. It can have that kind of look sometimes because of the thick skin that's involved. And this is really interesting. I really want to emphasize this slide, that this is an example of a patient who had a rash that was only on the scrotum. And sometimes you see this, that there's a patient who seems completely asymptomatic, but then when you do a thorough genital exam, you really want to look at the skin, not just for chancres on the genitals, but also for these like subtle rashes. And this can make the difference between someone having secondary syphilis and someone having unknown duration syphilis, which will change your treatment. So it's really important to do this well. Here's another example of oral findings. So these are mucus patches. You want to look not just under the at the tongue, but look under the tongue, look inside the buccal mucosa. Ask the patient to lift their lip up so you can look under the lips as well, and have a pen light, because sometimes these can be very subtle. Here's an example of patchy alopecia. You can see it has irregular borders. Sometimes it can also be subtle. And here are condyloma lata, which are really interesting because they look a lot like warts. And one thing that you can ask your patient when you're taking a history is, hey, did you have some anogenital warts and they were only there for a little while, like a couple weeks, and then they went away on their own? Condyloma lata will resolve on their own. Warts hang around. So, that's another way to distinguish between them. Or if you see somebody who has warts like this, or what seem to be warts, you can ask them, how long have you had these? And if you see something like this on exam, you could consider testing them for syphilis. For neurosyphilis, as I said, that can happen at any stage. Early manifestations include your cranial nerve dysfunction. So you want to think especially about hearing, about vision changes. Sometimes you can have altered mental status. For otosyphilis or otic syphilis, you can have hearing loss with or without tinnitus, that ringing in the ears. And for ocular syphilis, there is a range of visual symptoms because syphilis can infect multiple structures within the eye. So it can be anything from blurry vision to floaters to pain, depending on what eye structure is involved. For late manifestations of neurosyphilis, these are when someone has had neuro involvement for a decade, 2 decades, 3 decades. And this is when you get these signs of tabes dorsalis, general paresis. So all patients should be assessed for neurological signs and symptoms. That includes a neuro exam, including ophthalmic and auditory symptoms. And if there's clinical and evidence of neurologic involvement, then you want to do a lumbar puncture. Okay. And if a lumbar puncture isn't possible for people who have just eye symptoms or just otic symptoms, then you should refer them to an ophthalmologist if it's ocular symptoms, and you can consider treating them based on that. Now, for signs or symptoms, this is just a nice flow chart in terms of how to stage. If they do have signs or symptoms, then you distinguish if they have, is it a chancre with primary syphilis, is it rash, etc., and secondary syphilis. One thing to keep in mind is that sometimes people will start to develop secondary symptoms before their before their chancre completely heals. So it's not impossible to have both a chancre and the beginning of secondary signs. And if that's the case, then you could stage it as secondary, and the treatment is the same for both. Now, you can have neuro or ocular symptoms, and that's the other option of a type of a symptom. So that would be neurosyphilis. If there are no symptoms, then this would be latent, and that's when you have to figure out, okay, was this in the past or not? And that, like I said, can be based on a history of a negative syphilis serology or a 4-fold increase in titer within the last year if they've had a test that's available in the last 12 months. You can look for contacts who are known to have had early syphilis, or a very good history of those signs and symptoms that I just showed you, Or the last thing is if the only possible exposure was this year. So if someone, for example, had sex for the first time ever in the last 12 months. If the answer is yes to any of those, then it's early. If the answer is no to all of them, then it would be late latent or unknown duration. All right. Now, finally, congenital syphilis is typically due to transplacental transmission or vertical transmission. Very, very, very rarely, it could be due to a contact with an infectious lesion at birth. So if someone had a chancre in the vaginal canal, but the vast majority, I've never seen that personally, and the vast majority is through transplacental transmission. So that is associated with earlier maternal stage of disease and high maternal disease titers, meaning your VDRL and your RPR titers, which I'll talk about in more detail soon. The mortality is high. This is a study that was done by Pablo Sanchez, where he looked at 191 confirmed CS cases, meaning that the infant was tested with a rapid infectivity test and confirmed to have a treponema infection was found to be 35% or 1 in 3. Of those, 4 out of 5 were stillbirths. So I just want to say that again, 4 out of 5 CS mortalities were due to in utero death that occurred after 20 weeks gestation. And the majority of those stillbirths were by 28 weeks gestation, of 74% or 3 out of 4 stillbirths. So I really want to just emphasize that to drive home the importance of testing and treating for syphilis early in pregnancy, because often when you are doing testing later in pregnancy, you're at a higher risk of fetal mortality. Now, prenatal treatment does dramatically reduce the risk of CS stillbirth. So this is a really nice meta-analysis. It was done by Hannah Blenkow, published about 10 years ago. And she found that when treated according to stage, that it prevented stillbirth down to 18% of what it would be, or the adjusted risk ratio was 0.18. This is a mathematical model that was done by Gust et al. And this is based on data from the 1990s that, when congenital syphilis was also rising. And she found that around 70% of CS stillbirths were likely avoidable if treatment had been given by 21 weeks gestation. Now, I've been sort of talking about RPRs and VDRLs and the different syphilis tests. So I just want to get into that in a little more detail. That what the RPR and VDR tests are non-treponemal tests, which means that they're looking for an antibody that increases or decreases in response to the burden of syphilis. So these are not specific to syphilis. There are things other than syphilis that can make your RPR go up. But we use this as a proxy to see what disease burden is. And it also allows us to do quantitative titers that can be measured. So we can assess for reinfection and we can assess for response to treatment. This is my favorite syphilis graph. I know everyone has a favorite syphilis graph. This is mine. And what I want you to see is the VDRL and RPR lines, which are right, if you can see my arrow right here. And what you see is that the RPR and VDRL start to increase in the primary stage, and then at secondary stage, that's when they really peak. Now, if you treat, then they decline dramatically. If you don't treat, they also can decline, but not as dramatically as if you had treated. Okay, they can stay positive for a very long time. This is a sero-fast reaction, even if the person is adequately treated and cured. Okay. How to interpret them? Higher numbers correspond to higher levels of antibodies in the serum, which typically reflects a higher disease burden and more treponeme, which is why higher titers are related to a higher rate of vertical transmission, because presumably you have a higher bacterial load at that stage. A twofold change is generally considered within the margin of error. So that means that if you have a patient and their titer is 1 to 32, and then you give that same blood sample to a different technician. That different technician might read it as 1 to 64 or 1 to 16. So that's a twofold change. However, a fourfold change is considered clinically significant. So this would be if you had a 1 to 4, and then your patient comes back and they have their blood drawn again, and now their titer is 1 to 16. That's a fourfold change, unlikely to be due to human error, more likely to be due to something happening clinically. And if it's sustained for 2 weeks, it's considered to be significant. However, it's not unreasonable to empirically treat when you have that fourfold change, especially if you think that their likelihood of coming back for a repeat is low. It's reasonable to go ahead and treat based on that. You want to compare titers using the same serologic tests. So compare RPRs to RPRs, compare VDRLs to VDRLs, and RPRs tend to run a little higher than VDRLs. Now, for the treponemal tests, these are the confirmatory tests. So for people who are, and I'll talk about the different screening algorithms in a minute, but what I want you to know first and foremost is that the treponemal tests are specific to T pallidum. So if we're going back to this graph, you can see these two thick solid lines. There's FTA-ABS and TPHA, which is similar to the TPPA test that we use more often in the United States. That these treponemal tests look for antibodies that are specific to T pallidum, but once you've had syphilis, they will stay positive for life. So you can't use them to assess for reinfection or response to treatment. So that's the downside. However, if you have a patient who has a positive RPR and their T pallidum test is negative, their treponemal test is negative, then you know that that RPR is not due to syphilis, it's due to something else. That's called a biological false positive. There is something called a reverse screening algorithm, which is being used more often now. And in that algorithm, which I'll go through, the EIA or CIA tests are used as the first step. Finally, there are point of care tests. So this is one point of care test. It's a rapid immunochromatographic, assay. It's basically a lateral flow immunoassay. It's called Syphilis Health Check. It is only testing for the treponemal test. So one downside of this is that if you're working in a population where syphilis prevalence is generally high, then you might have a high number of people testing positive due to previous infection rather than current infection. But it is a useful test if you're interested in doing point of care. The results come back in 10 minutes and it's FDA approved, it's CLIA waived. When I was making this slide, which was a little over a year ago, it was about $8 per test. It might be a little different now. I mentioned the different algorithms. In terms of screening for syphilis, you have your traditional algorithm. For that, you start with your RPR. If the RPR is positive, then you confirm it with a TPPA or another TREP test. And then if that's positive as well, you know it's syphilis, either past or present. You need to confirm the patient's history. Or if the TPPA is negative, then that would be unlikely to be syphilis and probably a biological false positive. The reverse screening algorithm is when you start with an EIA or a CIA. And the reason that you would do this is because the EIA and CIA are automatic tests that can be batched. So they're especially useful if you are doing high volumes of syphilis tests in a setting where there's a relatively low prevalence. So you can do batches of tests. And if the EIA or CIA is positive, then you do your RPR, which is read manually. So this way you don't have to do every single person manually. If the RPR is positive, you have your diagnosis. If the RPR is negative though, you don't want to stop there. You want to make sure that this EIA or CIA is a true positive. So this is the one downside for this test is that the EIA and CIA can have false positives. And the TPPA is how you do that tiebreaker. So if you do a TPPA and it's also positive, then that confirms that this was a true positive EIA or CIA. And for that, you need to evaluate if this person had syphilis in the past, if they're at risk, then you could consider repeating the RPR, and you need to evaluate them clinically, excuse me. If the TPA is negative, then you can always repeat the RPR in 2 to 4 weeks anyway, if you are concerned. Okay, there's also the option if you have incubating primary syphilis, and that's what you think might be going on, you can go ahead and treat them. About 25% of people with primary syphilis have a non-reactive RPR. All right, so obviously there are lots and lots of diagnostic challenges we've talked about. You can have false negatives like early primary and late stage and latent stages. Like I said, 25% of primary cases can have a negative RPR. There's also something called a prozone reaction, which is when you have a titer that is so high that it essentially overwhelms the test because the antibodies are so high. And so if you have somebody who has secondary symptoms and then their RPR comes back negative, but you have a very high suspicion, you can always call your lab and say, hey, did you rule out prozone? There also are biological false positives that I mentioned. You can have an RPR or a VDRL that's positive and then the TREP test is negative. This could be due to a viral illness, which includes HIV. Recent immunizations are a possibility, although data is kind of on the fence right now about it. And then also autoimmune and chronic diseases can contribute to that as well. And then you can have the discordant serology, which we just discussed. So in terms of treatment, you want to treat syphilis by stage in pregnancy. For the primary, secondary, and early latent syphilis, you treat with benzathine, penicillin, 2.4 million units times 1. And if they have latent or unknown duration, then you give 3 doses of benzathine penicillin, and you want to do that every week for 3 doses. CDPH recommends 6 to 8 day intervals, and that's in light of high statewide rates of CS. So because our rates are so high, we say 6 to 8. The CDC recently put out guidance saying that beyond 9 was considered a missed dose. We would consider beyond 8 a missed dose. And that's, again, in response to our high burden of CS in the state. Okay, the only treatment is penicillin. That is it. That's all we've got. The alternative for people who are not pregnant is doxycycline, but for pregnant people, you have to treat them with penicillin for the regimen that's appropriate for their stage of infection. And if you have somebody who says they have a penicillin allergy, then typically what you would want to do is explore that allergy history and confirm that this is actually a type 1 IgE mediated allergy. If it is, then you need to desensitize them, and that can be in collaboration with an allergist in a hospital. And then one other note is that women who are treated in the second half of pregnancy are at a slight risk for premature labor or fetal distress as part of something called the Yarish-Herxheimer reaction, which is kind of a transient reaction to the syphilis treatment. And you can have, sometimes you'll get a little fever. And so for that, some providers will do the treatment with the patient on the floor in the hospital. But any concern for that treatment should not delay it, okay? Overall, it's very, very effective. 98.2% in a study that was done by Alexander in 1999, which is one of our seminal studies. They found that for secondary stage, which is one of the higher, when we have a higher burden of disease, there's a slightly lower efficacy, but it's, so you do have a higher risk of treatment failure during early syphilis, and you do have a slightly higher risk of treatment failure later in pregnancy. So if you treat somebody at 36 to 40 weeks, you're slightly less likely to prevent CS, which is one of the reasons why we really emphasize treat early, test early in order to prevent congenital syphilis. Now, in terms of follow-up, for primary and secondary syphilis, you wanna, if they had symptoms, you wanna make sure that their symptoms resolve. And then you repeat titers at 6 and 12 months. You do that a little bit more often if they have HIV. You want to look for that 4-fold decrease in titer, and that should happen by 12 months. For people who have HIV, it might take a little longer, up to 2 years. And clinically, trials have demonstrated that up to 20% of people with primary or secondary syphilis who have that therapy will actually not reach that goal at the first year of treatment. So sometimes you do have to wait a little longer. For latent syphilis, for people who are treated, you want to repeat titers at 6, 12, and 24 months. And you go out to 24 months regardless of HIV status. The difference being that if they do have HIV, you can also test them at 18 months. But similarly, you want to see that 4-fold decrease. And that's especially true if they have a titer that is 1 to 32 at diagnosis. If you have a lower titer, sometimes you're more likely to become serofast, and you might not see that 4-fold decline. All right. Now, finally, I'm very excited in the last couple of minutes to talk about the expanded screening guidance that CDPH put out in 2020. So it's been out for about a year. And one of the reasons we're all gathered here today is to talk about a specific recommendation statement, which is to screen in emergency departments. And so the recommendation is that emergency department providers in local health jurisdictions with a high CS morbidity, which I'll describe, should consider confirming the syphilis status of all pregnant patients prior to discharge. And that can be confirmed either via a documented test result in pregnancy or a syphilis test in the emergency department if you're not able to document it, or if you don't have documentation on hand. One of the reasons that this is so important is because a high proportion of our state's congenital syphilis cases are born to birthing parents or mothers who are not in prenatal care. And there are various reasons why they're not in prenatal care, but for whatever reason, that prenatal care is not accessible. There's also a high rate of people who are unhoused or unstably housed, and a high rate of people who are using drugs like methamphetamine. And so because of all of these different factors, often we see cases where people will go to the emergency department as needed for care, but that's their only interaction with healthcare during pregnancy. I wanted to define high morbidity. So the way that we define high morbidity in California is a rate of 8.4 CS cases per 100,000 live births in any of the past 3 consecutive years. So take a look at this. This is based on 16 to 18 data, and you can see if your county is high risk. And like I highlighted, in California, the majority of mothers who give birth to a CS infant have delayed or no prenatal care, and just a little over half report having used meth. Incarceration and homelessness are also. And what I want you to keep in mind is that the people, infants who have congenital syphilis, who were not able to prevent vertical transmission via detection and treatment, are typically living in a situation where they have a very complex set of social determinants of health that includes poverty, healthcare disparities, disparities in access, and also stigma. And so that's why emergency departments are one of the ways we think we could reach people who are not able to access care otherwise. A couple things about the rationale. So this is one review that was included in the treatment recommendation, or excuse me, screening recommendation. There were 2 local health jurisdictions with a high CS morbidity, and we looked at data from October 1st, 2017 through 2018, and that included 123 people who delivered an infant with congenital syphilis. We found that 16% of them were seen in the emergency department during their pregnancy, and that of the 20 people, or 16%, 80% lacked any other prenatal care. So there were basically 16 cases where the only opportunity that they had for care or syphilis detection was their emergency department visits. Here's a California code. This is Senate Bill 1152. And it places the following wording into the health and safety code. It talks about homelessness, which is why I wanted to include it here, that the homeless patient has been offered or referred to screening for infectious diseases common to the region as determined by the local health department. So if you are in a local health jurisdiction that has high congenital syphilis rates, this is one way that you can think of how congenital syphilis can impact patients who are homeless, which, as we saw, impacts about 25% of parents of CS infants. Okay, a couple more slides on this. Here is one example outside of California where they looked at the benefits of syphilis screening in emergency departments. This was in Miami, or Miami-Dade County, and they had an enhanced routine screening infrastructure where they incorporated syphilis screening into the emergency department, and that was triggered by either a pregnancy test or the patient was complaining about something that might be syphilis, or they had a history of an STD. And so they did this from April to December of 2018. They did over 2,500 tests, and there was a 2.7% positivity rate, which is high. So of these, here you see your 68 or 2.7% positivity rate. Of those, 17 were among pregnant patients. So 25% of the people who had a positive result were pregnant, and they were treated. And they found that this ended up preventing 6 congenital syphilis cases. In other words, these 6 of these, and that isn't to say that the 11 others went on to have congenital syphilis. We don't know what happened to the remainder of those pregnancies, but we do know that at least 6 were prevented. Okay, and then finally, here's another study from New Orleans. This was done in 1991. So again, a different era, but when syphilis was similarly on the rise. This looked at screening in emergency departments, and they identified 8 cases of previously undetected syphilis among 72 pregnant women who were screened. And that was only over 6 months. So you can see that that's about 1 in 9. And then 7 patients delivered live infants, meaning 8 of those 8, 7 of them delivered live infants, and none of them had reactive serology or signs of CS. Okay, so finally, I want to end on just 1 or 2 slides about how to think about your protocols as you're implementing this into your emergency department settings, and then I'm going to hand it over to Dr. Lyons to talk more about it. But one thing is think about your electronic health records and what kind of alerts you can put in to cue somebody to do that syphilis test when it's appropriate if you have a patient who's pregnant and would require that. You can also think about what type of test. So do you have a rapid syphilis test available, either a rapid RPR or a point of care? A point of care test is another option, although I think the RPR might be a little more realistic. And then do you have presumptive treatment on hand? That's another thing that's very important. You want to screen as early in the visit as possible if testing, so you don't have to wait too long for the results. And you want to, like I said, take steps to ensure that timely, adequate treatment, whether that is giving empiric or, giving presumptive treatment, or making sure you have a system to link to treatment that's very close. Now, this is one study I just wanted to end on. I thought it was kind of cool. This was a study that was published this year looking at emergency department syphilis and gonorrhea and chlamydia co-testing in the emergency department before and after the implementation of this record-based alerts. So basically, anytime a patient was, this is very simple, anytime a patient was tested for gonorrhea and chlamydia, you also ordered a test for syphilis. And so this isn't specific to pregnancy, but I think it's a nice example. And then they compared the pre-intervention to the post-implementation over the same periods of months, so January to November of 2018 and 19. And what you found was that for new diagnoses, pre-implementation, they diagnosed 37 cases, and post-implementation, they diagnosed 87. So they diagnosed more cases, and of those 87, 48 of the diagnoses were because of this alert. The test yield was only a little higher, so it went from about a 7.5% to a 7.9% increase, so not a ton higher in terms of yield, but the number of cases was higher. All right, so I'm going to stop sharing my screen, and I'm gonna thank you all very much and hand it over to Dr. Lyon. And so, Dr. Lyon, the stage is yours.
Thank you. Let me just get my screen up. And we should be good there. So thank you, Dr. Plotzker. I appreciate all the information you have presented. I'm going to discuss our experience in Kern County. And I'd like to first start by sharing a little bit of the Kern County specific data. As you had seen in the initial slides from Dr. Plotzker, the state definitely has a problem with syphilis. Well, Kern County is unfortunately at the top in the ranks of syphilis. Our syphilis cases for all stages have doubled since 2017. And in primary and secondary syphilis, we are extremely high in comparison to other areas. And to see that comparison, this graph shows the rates comparing Kern County, California, and the entire United States. Kern County being 37% higher than the state average and 140% higher than the national average. As our rates of syphilis have increased throughout the entire population, we are also seeing increases with primary and secondary syphilis in females. It's about 46 times as high as it was in 2010, which is when we really started seeing our rates increase, which has also then caused our congenital syphilis to start increasing just a couple of years after that initial incline. We had seen a little bit of a dip in 2019, and hopefully in response to some of our actions, but we're very concerned with what is going to happen as a result of the pandemic and the limited availability of care, especially early in the pandemic. And comparing Kern to the state and the country, our congenital syphilis rate is 2 times as high as the state average and 5 times as high as the national average. So why the emergency department? As with HIV patients, I think syphilis patients are pretty similar, but HIV patients are 3 times more likely to visit an emergency room, be racial minorities, and lack health insurance compared with their non-HIV counterparts. The emergency department is truly the safety net. It is often the only point of entry into the healthcare system for many of our patients in our community. And during the pandemic, this may have been the only option for care for some people. So in my role as the health officer, but also as a practicing clinician in the emergency department, I was able to bring together 2 of our emergency departments to implement a focus program where we were testing for HIV, Hep C, and we added syphilis. So typically the focus program did not include syphilis, but we asked our hospitals to include syphilis due to our rates. And they graciously did that, even though they did not receive any funding for the syphilis testing up until now. So now focus is adding syphilis reimbursement on as a surrogate for high risk for HIV and prevention of HIV. And the focus program reimburses for unfunded testing, as well as funding for linkage to care coordinators. It also provides resources for education and has really helped kickstart our program. Some have felt that there is risk associated with doing all this testing. However, we have a very close relationship between our emergency departments as well as the public health department, which helps to actually decrease the risk because of the layers of follow-up as well as linkage to care that we are able to do with that partnership. And the way I look at this, the risk question, is also how many of these patients are coming through the emergency department, both syphilis and HIV patients that have repeat visits to the emergency department without any of this testing being done. And it is really something that I think we can make a difference for our patients. And how we actually implemented this is through an opt-out process. Now, the opt-out is not required for the Hep C and syphilis, but is required by regulation in California for HIV. For ages 12 and older, written consent is not required for any of these. We do ask our clinicians to inform the patient and document when a patient declines testing. However, if you present this in a very simple way, no one declines. So for example, if I'm seeing a patient in the emergency department, I tell the patient, we're going to order a chest x-ray and we're going to do blood work. Whenever we do blood work, we do HIV, Hep C, and syphilis testing. That sentence is my opt-out statement, and really no one says no. Can also add signage prominently in the ED as well as the hospital. If possible, adding it to the general consent for treatment really covers the hospital from all aspects. But again, it's not required for syphilis or Hep C, but we have implemented because it is a package program. And as you'll see in some of the slides that I present later, automated testing is truly critical. So having clinicians manually order tests is one extra thing that they have to remember to do, so it becomes pretty inconsistent. So this is our automated order that is triggered when our nurses go through the triage process and click that the patient has not declined the testing. And that's ordered based on a CBC as a surrogate. So anytime a CBC is ordered, the patient's 12 and older, they have not declined testing, and they haven't had testing done in the last 12 months. Although we're talking about 6 months as a testing cutoff for our labor and delivery patients, then that test will be automatically ordered. So we're not ordering this on patients that otherwise would not be getting blood draws. But to show how different it is when you have an automated versus manual system, the light blue bars are from one of our emergency departments, was actually the first department that started with our testing program. They actually see more patients, significantly more patients than the emergency department in dark blue. Now they are both probably the top 2 in volume in our county, but you can see how the automated testing, which is the dark blue, is significantly more, and the manual testing is less. So this is a longer view of our automated testing program site. And you can see, even despite COVID, it is very consistent. You actually can follow some of the COVID peaks if you plot this out long enough. And we get about 5% back as a positive initial screen. Now, that hospital that initially started with manual testing was able to transition to automated testing. And you can see the dramatic increase in the number of tests they've run, and are now doing more tests than the other hospital that initially had the automated testing. And this graph is kind of interesting because it shows our preliminary positive test. in the blue. And then it shows that we do have clinicians treating in the emergency department. It's not perfect, but we are getting patients treated. The November data is still preliminary, so those aren't completely accurate in terms of how many were treated versus untreated. But it does go to show that we are getting patients tested, identifying and treating patients. And we do ask our clinicians to tell the patients for all these, not just syphilis, but HIV and Hep C, that these are preliminary tests and require confirmation. But we do ask that our clinicians treat everybody based on the initial preliminary test result. So we give everybody a dose of penicillin. At least that's our goal, is to give everybody a dose of penicillin if they have the preliminary test result come back positive. And our tests do come back during the ED stay. They usually take an hour to hour and a half and are well within the typical patient's ED stay. So I'm going to move now to some data based on what we're seeing from this specific testing program. In women of childbearing age between 2018, which is when our first program started, and November 2021, we had a total of 2,005 positive test results. And of those, 1,629 were identified as new cases. And in that same group of women of childbearing age in the same time period, 672 positive tests were ordered or performed in hospital EDs. So that's 34% of our positive tests were ordered by hospital EDs. And of those, 84% were new syphilis cases. In the same group, in the same time period, we see that 96% of the positive tests were from hospitals that were performing routine opt-out testing. So 96% of the positive tests were done at hospitals participating in this program, the 2 hospitals. And 85% of the positive test results from root hospitals were new cases. Of the 338 positive results identified in pregnant females, 17% of positive test results were in pregnant. And in the 262 pregnant patients identified as new cases, they accounted for 78%. And 74 pregnant females were identified by hospital EDs. That's 28% of our total positive pregnant females. And of those, 93% were identified in hospitals participating in the routine testing program. So while there were 159 congenital syphilis cases identified during this time period, there were 565 congenital syphilis cases ruled out. 60% of pregnant females were treated prior to pregnancy, and 24% were treated during pregnancy. 34% of women of childbearing age received treatment for syphilis in the hospital ED, although they may not have received the entire course, because if they were identified as late latent, we would arrange for them to follow up with public health for their further treatment. And again, 96% of the women of childbearing age treated by hospitals were treated at hospitals participating in the routine opt-out testing program. To summarize that, 78% of congenital syphilis cases were avoided by adequately treating the mother. 60% of females of childbearing age were treated prior to pregnancy, and 24% were treated during pregnancy. 34% of women of childbearing age received some syphilis treatment in the ED, and 96% of women of childbearing age who received syphilis treatment in ED received it from a facility performing routine opt-out testing. 28% of pregnant women were identified in hospital EDs, and 90% of pregnant women identified in the hospital EDs were identified in our opt-out testing programs. So why are we doing this? Because we can make a difference. We can decrease the morbidity and mortality associated with syphilis. We can decrease transmission, and we can decrease or eliminate congenital syphilis. So I ask you not why, but why not? So I think we've shown that this is an effective process. I'm happy to take any questions, and you're more than welcome to email me at that email address. So that concludes my presentation.
Wonderful. Thank you so much, Drs. Lyon and Plotzker. That was super informative. We heard a lot of summary and review about syphilis itself, and then a very specific and interesting intervention about how to encourage and complete syphilis testing through emergency departments, and what a critical place it is to be doing that kind of testing. So really appreciate both of you guys speaking with us today. We do have questions in the chat, so I'm just going to go ahead and ask away. I'll just start up at the beginning. This was a question. I'll just direct it to either of you. I thought it was a good question. Is screening not part of a standard preconception health visit? Like, for those who explicitly say the appointment is to discuss trying for pregnancy, would you recommend syphilis screening, or just still risk-based screening in that setting?
Well, I think that's a really interesting question. I think, if someone, you could, I mean, I don't see why not. If someone's going to be planning to conceive, and this is something that is part of a prenatal visit, you could do it. I think that you would also want to think about their risk. I think that if they did, my caveat to that would be that if they did decide to do in preconception screening, they did a syphilis test and it was negative, I don't think that that would preclude them from having a first prenatal visit syphilis test as well. But yeah, I think that's reasonable.
Yeah, I agree. It wouldn't be in the standard technical recommendations, but certainly not wrong to do. Of course, the screening would have to be then repeated when they were pregnant. So
Yep.
I agree with that answer. I think it's an interesting question. Then Dr. Plotzker, one more for you, and then lots
Yep.
of questions for Dr. Lyon. So going back to your summary of neurosyphilis, question about, would neurosymptoms include things like paresthesias or stroke symptoms if stroke has been ruled out?
It could. I think it would be rarer. I think it would be a rarer manifestation, but it could.
So basically, if you're having a patient with unexplained neurosymptoms, perhaps an LP and including that CSF VDRL
Yep.
would be appropriate in the workup.
Yes, Dr. Johnson.
Wonderful. Okay, now lots of questions for Kern County and for Dr. Lyon about your process, and I'll just take it from the top. So lots of people get a CBC. Is there any issue related to cost to the healthcare system and charges to the patient? May save the system money, I'm assuming in terms of syphilis overall, but where does the budget come from?
So overall, the hospitals were really concerned about denied charges, and thus far have not been able to bring any examples of denied charges. And so most of the people that have insurance, this is being covered under preventative health screening. And I think if you look at how much we save if we can prevent a case of congenital syphilis, and I think it's worth doing. And the FOCUS program then reimburses for those patients that do not have insurance.
Got it. Thank you for clarifying. And I have sort of a related question that I'm going to add on to. The question from the audience was, did any of your emergency medicine colleagues complain that this should not have been done in the ED? And my follow-up question to that question is, I've heard some ED settings where folks are nervous about doing this kind of testing. If you don't have results right away, like who's going to follow up with the patient? So just wondering if you could comment both on if anyone had concerns, and if they did, how did you address them?
We're emergency physicians, we complain, so yes.
Okay, so yes, there's some complaining.
There's a lot of things that we're asked to do that are really seemingly unrelated to the active patient care. Yet when you look at what we're doing, and we have so many examples of how this program has impacted patients, not only in the syphilis testing, but the HIV testing. I mean, we have numerous cases of new HIV diagnosis in patients that have touched the healthcare system in multiple different ways. Multiple different hospitals, clinics have had surgeries and were never tested or never suspected. And so I'm trying to do a better job of bringing those cases back and having our clinicians understand that this is not just a public health endeavor, that this is clinically relevant and it is important to our patients and our community.
Mm-hmm. So lots of advocacy, it sounds like, around the importance, and maybe using specific cases to highlight why it's important might be a way to address concerns. Does that sound right?
And I think with we have a very close working relationship with public health and our linkage to care coordinators. And I think that helps protect our clinicians if they have a concern about the risk. And so that we don't ask them to keep patients for the test results. If they are ready to discharge the patient, they discharge the patient, and our linkage to care coordinator works with our public health disease investigators to then contact the patient and arrange for treatment and linkage to care.
Got it. So you have folks to follow up on results and help connect the patient to care through public health. Great.
Yes.
Wonderful. Okay, more questions for Kern County. What would you say is the #1 factor for doubling of syphilis in Kern from 2017 to present? Is it homelessness, meth, something else?
Thank you, Tom. I appreciate that question. And I think it's a combination. I think meth definitely as well as opiate substance abuse does play a large part. I think there's a lot of socioeconomic aspects that play a part, access to care. And people just don't think that they're at risk, and a lot of people don't even know. So I think there's a lot of things going to it, but I think meth and opiate addiction do play a pretty large role in this.
Mm-hmm. Sure. And I'm sure there's some access to care issues too, especially during COVID when things were shut down during the pandemic, where the ED may have been the only place that people knew or were able to access care. Okay, another question for Kern County. Is Kern prioritizing women of reproductive age for syphilis screening, or pregnant women? Or is there any difference in who you run your syphilis screening on in your EDs?
So specifically to the emergency department, it's everybody. So we screen everybody 12 and older that's getting a blood draw that doesn't decline and hasn't had the testing done in the past year. And our clinicians are encouraged to order repeat testing within the year if the patients are at high risk. So we don't target any group of patients at this point. However, with some of our new focus contracts that were just awarded, we are having our hospitals expand to labor and delivery. And so just to augment what the labor and delivery is already doing to just make sure that we don't miss anybody, we are going to automate testing in labor and delivery at both these two hospitals. We are also working with 5 additional hospitals and one large FQHC that is implementing testing as well.
Wonderful. So lots of innovations going on in Kern County, it sounds like. Thank you for all of those answers. Then in our last minute, just a few comments in the chat. Getting back to the question of should you do syphilis screening at preconception visits, we have a comment stating appropriately, and as has come up during this talk, that many clients actually don't have preconception visits. There's a lack of care access, drug use, homelessness, etc. I think that's a fair point. And again, you would want to still screen in that first prenatal visit, regardless of trimester, but ideally in the first trimester, even if this patient never had a preconception care visit. And another FYI, thank you so much. FYI, Kaiser Permanente in the Bay Area does full STD panel, including RPR for all patients in the infertility clinic, regardless of risk. So at least one setting in which that kind of testing is happening in the preconception or infertility counseling type of setting. And we are right at 1:15, so I'm going to stop the Q&A there. I think we've actually answered all of the questions. Thank you so much for sending them in through the chat and the Q&A. And for the conference organizers, is there anything else you wanted to bring up before we close?
Oh, actually, really quick, I need to share the final CME slides, which I realized I neglected to. I'm so sorry. Let me share my screen. All right, sorry about that, everybody. So here's just some important CME information. Here you go. So a reminder, I know you've seen this already, but just to refer back to it if you have any issues with CME. Hopefully this will be helpful.
Wonderful. So with that, I think we'll close there. Thank you all again for being here. We really appreciate it. Have a good day.